Okay, it's about 5:30. I'm just going to do some housekeeping right now before I introduce Dr. Kostis. Or should I give, let me just see, should I give just a couple more minutes? I can do that. I can wait a couple more minutes. Well, I think we have some solid audience here, so
Yeah,
I'm going
I agree.
to go ahead and do the basic housekeeping. I had just have a couple of slides. We have a fantastic cardiology grand rounds today. We are going to be listening about contemporary device-based management of heart rhythm disorders as well as heart failure. We have our very own Dr. Will Kostis, who's going to be doing the talk. For cardiology grand rounds, if you want to listen to the grand rounds later, it is on the YouTube link, and the link is posted right here. It'll be also be in the chat. And for the CME credits, please follow the step 1. Text 25674 to 888-816-4893 within 12 hours after the session. You have to send us an SMS message. And if you want mock points, you first have to complete the step 1. Then you answer a brief quiz. And the quiz is, you can either scan it on the QR code on the right or go into the besocreative.com /login/student with the room code of future 2025. With that, I'm just going to switch gears and talk a little bit about Dr. Kostis before we will get the presentation started. And I'm going to stop sharing as well, so Dr. Kostis can share his slides. It is my pleasure to introduce Dr. Kostis to all of you, not that you don't know him. He is one of the most amazing physicians, researchers, and also mentors that I have encountered in my long career. He actually completed a PhD in electrical engineering from Cornell University, after which he was appointed as an assistant professor of electrical and computer engineering in radiology at Will Medical College of Cornell University. He then subsequently got his medical degree from Rutgers Robert Wood Johnson Medical School. He subsequently completed his residency at Hopkins, followed by a cardiovascular fellowship at Mass General Hospital. He also completed a research fellowship in medicine at the Harvard Medical School in 2014. And he was appointed as instructor of medicine at Harvard Medical School and assistant professor of medicine at Mass General Hospital. In 2015, he was recruited to RWJMS as an assistant professor, and now he's currently a professor. of medicine. He served in multiple roles since he had been here. He was the director of EP research. He was the associate program director for cardiovascular disease research. He also was the associate program director for cardiovascular fellowship, uh, and he was the director of EP research and development. He was, more importantly, one of the most fascinating research works that has come from him was from when he was an undergrad student.
Mhm.
And the way that he actually looked at the MIDAS database and taught us all as to how to treat patients who are coming in with STEMIs over the weekends who were not getting adequate care actually translated into STEMI guidelines, which is so absolutely amazing for a student, for an undergrad student, no less.
Well, actually, I was an undergrad medical student. I have my PhD already.
Yeah.
Yeah.
He also is very closely involved with the SPRINT study. And this actually also led to a change in guidelines about how orthostatic hypertension actually increased cardiovascular mortality. And MINT study, and he is still very closely involved with that, and CERT study as well. And some of these activities may sound very easy to do, but they are one of the most difficult things, honestly, because this requires a ton of database research, a lot of looking at patterns. And he was able to utilize his computer skills as well, computer science skills, to come up with how to actually predict the mortality. And one of the other things is, well, you really should be in imaging. Some of the work that you have done, once again, translated into looking at pulmonary nodules and being able to, and that also went into the radiology guidelines.
That was my
That
PhD
got
dissertation. Yeah.
Yeah, this is just absolutely amazing as to how you're changing patient management on a large scale. These are not small things, small endeavors. He also has demonstrated national service recognition in numerous professional organizations. At the international level, he's been serving since 2018 to now an important role, and this is one of the steering committee members for the hypertension management. And he works really closely with our ESC colleagues on in that role. He also is a committee member for ACC's NCDR ICD Registry Steering Committee, as well as NCDR EP Registry Steering Committee, as well as the convener of International Expert Consensus Committee on Visit-to-Visit Variability of Blood Pressures, all of which are extremely important work. And lastly, he's one of the most beloved teachers. He has mentored multiple people, from students to residents to fellows. And he's one of the most compassionate, energetic, hardworking, intellectual people that I have ever come across. And I have to say, Bill, you picked up the phone and welcomed me, and I'm never going to forget that
Hmm.
as soon as I came here. So with that, we are going to turn over the podium to you. So we are just waiting.
All right. Thank you, Kamu, for the extremely, probably overly kind introduction. I'm not sure I can live up to that, but I will aim to. Uh, let's see if I can share the thing I want to share. Can you guys hold on one second? I think I clicked the wrong button. Can you guys see the slides?
Yes.
Okay, wonderful. So, so I was asked to give grand rounds, and today's topic will be contemporary device-based management of heart rhythm disorders and heart failure. I was thinking about what to do when I was asked. I did a grand rounds a couple of years ago about risk estimation strategies for sudden death, which was very sort of detailed and physiologic and in the weeds and lots of data. And I decided to do something different for today's talk. and give kind of a 20,000 foot overview of how we use devices for heart rhythm disorders and heart failure. So hopefully that will be of interest to you guys. How do I advance my slides? Here we go. These are my disclosures for funding. I assure you that I'm trying to stay as vendor neutral as I can in this talk, with the exception of a couple devices that are only available from single vendors at this point. So the objectives for our talk today are to learn about the types and indications for pacemakers, for ICDs, and for other current and future directions in cardiac implantable electronic devices for arrhythmias and heart failure. So, as you know, in cardiovascular medicine, a majority of conditions that patients have may be treated with medical therapy and or with the addition of minimally invasive procedures. When it comes to arrhythmias, there's medications that can either slow or speed up the heart, although the positive chronotropes are generally IV, so that's you're limited to the intensive care unit. We can use catheter ablation to treat AFib, aflutter, other SVTs, and VT. When it comes to heart failure, we have a whole host and an increasing group of goal-directed medical therapy agents and inotropic therapy, as well as right heart catheterization. But when these non-invasive or minimally invasive therapies are insufficient, implantable cardiac devices can be helpful for a lot of patients. So in this presentation, we'll discuss the panoply of CIEDs for the treatment of arrhythmias as well as heart failure. These include pacemakers of both transvenous and leadless types, ICDs of both transvenous and non-transvenous devices, a bit about cardiac resynchronization therapy, or CRT, a bit about conduction system pacing, which is where the field is really going now, and I'll spend a few minutes on other devices for patients with LV systolic dysfunction. So I always like to include a little bit of history. Pacing history goes back much further than this, but really the first reliable systems for cardiac pacing were developed about 70 years ago. Paul Zoll invented transcutaneous pacing, which we still use to this day. As many of you know who have seen it or used it, it's very uncomfortable, so it's hard to use as a long-term solution for people, though it can be life-saving. About 7 years later, Earl Backen, who ended up founding Medtronic, and Lillehei, who was the surgeon, had external pulse generators connected to leads that were epicardial on the heart that were externalized transthoracically. This was a bit better and more comfortable, but obviously not a great long-term solution. Around the same time, Senning and Elquist in Europe invented a fully implantable pacemaker that you can see here with an abdominal pulse generator. There's a picture of it on the left, and epicardial leads that were placed on the heart. This was pretty good, other than the fact that the battery life was not very good, and they created an inductive charging system where the patient had to be on a charger for about 12 hours a week. If you think your cell phone is bad, this was a big burden for patients. So in the following year, a surgeon named Chardak and an engineer named Wilson Greatbatch developed the first long-term use fully implantable pacemaker system. There's Wilson Greatbatch there with his oscillator circuit that actually made this possible. Very, very low energy used to actually pace, and he developed some battery technology too. Here's an example of one of the earlier pacemakers, not the first, because as you can see here, this was after he sold some of his designs to the Medtronic company. Vic Parsonet, who some of you may have known, he passed away in December, unfortunately, at the ripe old age of 100. Was at the Newark Beth Israel and was a pioneer in cardiac pacing. He was one of the first to use transvenous pacing leads. There was a guy in Sweden named Ekström who also did that around the same time. And he, among other things, was one of the founding members of NASP, which ultimately became the Heart Rhythm Society. So for modern pacemakers, we have those that are both, well, permanent pacemakers, that is, both transvenous and leadless devices. They could be single chamber, dual chamber, with cardiac resynchronization, or with conduction system pacing. And we're going to talk about all these things. So the point of a pacemaker, obviously, is to prevent bradycardia via pacing in one or more chambers, or to provide cardiac resynchronization when indicated. They help to promote AV synchrony when you have dual chamber or CRT devices. That's useful in patients with high-grade or complete AV block. They can provide rate and electrogram data and other diagnostics about the patient's cardiac function and rates. Modern pacemakers have a longevity of somewhere between 10 and 15 years. And some devices also include therapies for pace-terminating atrial arrhythmias. And so here's a chest radiograph. The way that we implant these, as some of you may know, is to make a prepectoral pocket, usually on the left side. Sometimes in selected patients, rather than going on top of the pectoralis major, we go either intrapectorally in the muscle or subpectorally below the muscle. And then transvenously, as Dr. Parsonet taught us, here's a lead. Can you see my mouse, by the way? Lead in the right atrial appendage and one in the RV, hopefully on the septum. Here's a lateral chest X-ray of the same device. Here's another dual chamber pacemaker with older leads, what we call passive leads that are tined rather than having an active fixation helix. So, and this is a conduction system device that we will talk about later. So, which patients benefit from permanent pacemakers? Well, there's a lot of detailed guidelines, and I'm going to spare you those in the spirit of this overview talk. But in general, you can break them down to a couple of different conditions. People with sinus node dysfunction, with symptoms due to sinus bradycardia or chronotropic incompetence, in other words, inability to increase your heart rate with exercise, and the combination of sinus node dysfunction and paroxysmal atrial arrhythmias with conversion pauses is called the so-called tachybrady syndrome. In acquired AV block, whether it's complete heart block or high-grade AV block, or for Mobitz 2 AV block, which is unpredictably progressing to complete heart block, we often implant dual chamber pacemakers, infrequently so for AV Wenckebach, unless patients are really symptomatic. And there's a variety of other indications for pacemakers, but the bottom line is virtually all indications for chronic pacing require symptomatic bradycardia. If somebody's a trained athlete and they come into your office and their heart rate's 43, if they don't have symptoms, you just watch them. So what are some of the complications of these procedures? You can have device and lead infection. That's about 2%-ish of the time. Cardiac perforation. There could be pneumothorax, depending on your vascular access method. Vascular and nerve injury. You can have lead dislodgement, whether that's macro dislodgement, where the lead's bouncing around disconnected, or micro dislodgement, where it sort of tweaks its position and has bad electrical parameters. Leads can fail from conduction fracture or breach of insulation or long-term mineralization of the contact with the myocardium. You can have failure of the generator, in some cases with early battery depletion. And when you have these problems, sometimes you need to extract pacing systems. And if it's within the first year, year and a half, usually this is not a big deal. After that, there's enough fibrous tissue holding the leads in place that you often need more advanced techniques like laser lead extraction. Laser lead extraction is something that has become much safer than it used to be, but there's still a fair bit of morbidity and potentially mortality associated with it. So you'd like to avoid it if possible. So in that spirit, is there a way to avoid some of these complications with alternative pacing designs? And do you need both pulse generators and leads? I'm sort of hinting here, particularly because many of the complications are lead related. And to be more concrete, what if we didn't need leads? Well, sometimes we don't. Over the past few years, we've had the development of leadless permanent pacemakers. These also prevent bradycardia via pacing. They're single chamber systems in the right ventricle and now dual chamber systems in the right ventricle and the base of the right atrial appendage. In some cases, these can promote AV synchrony, either by the new dual chamber systems or with the single right ventricular system available from one of the companies. Basically, it has a 3-axis accelerometer, and when there's atrial systole, the pressure wave in the right ventricle can be sensed by the device, and it could figure out when atrial systole is and do ascens V-pace without an electrical signal in the atrium. Works great for some people and less great for others. So they can provide some other diagnostics, and depending on the device, the longevity of these leadless pacemakers is anywhere from 6 to 19 years. This is sort of a relative size diagram. You see a dime, a quarter, and a AAA battery. These are the 3 vendors that currently manufacture leadless pacing systems. So how are these implanted? Well, rather than making this incision on the left upper or right upper chest, these are implanted via venous access in the groin, usually the right femoral vein, but sometimes the left femoral vein, and on occasion the IJ. It's a pretty big delivery system that's advanced into the heart and into the right ventricle. Once you've affixed this into the right ventricular septal myocardium, and you know that by 2-view fluoroscopy and some injection of contrast to see the trabeculae, you can test it and make sure it's connected properly. And once you're satisfied, you cut the tether that's holding it and pull out the delivery system, and you're done, essentially. Here's an example of one of those leadless pacemakers, which maybe you can see here. It's affixed to the right ventricular septum, in this case a little high, but not in the RVOT, I can assure you. You may notice that there's a right-sided port in this patient for chemotherapy. More on that in a moment. Here's another leadless pacemaker in a different patient for whom you may also notice that there's a left-sided Shiley for dialysis in this patient. And here's a lateral view of the leadless pacemaker on the septum in this patient. So the newer sort of dual chamber system from a different vendor is implanted using similar techniques, a little bit of contrast, multiple view fluoroscopy, and a delivery system that's advanced to the heart through femoral venous access. Here's a couple of a PA and lateral of the combination system here. Here's one that my colleague, Dr. Maglione, did the other day, notably through a bioprosthetic valve, which is a trick, but it can be done. So what about complications of leadless pacemakers? Well, many of them are the same as compared to traditional transvenous pacing systems. However, there are differences. Infection of leadless pacemakers can happen, but it's almost case reportable. It's actually very rare. And the reason for this is there's no pacemaker pocket, there's no pulse generator, and the surface area of these devices is very small, which is thought to be why biofilm formation is less of a problem. Cardiac perforation can happen. Pneumothorax is extremely unlikely unless you're doing something wrong or there's an unusual access method like axillary venous access, but I don't think you can do that with these. You can have femoral vascular or nerve injury. The device can dislodge, but that's uncommon. All devices can fail ultimately, but the failure rate tends to be low. Of import is the battery longevity of these devices. So the devices from one vendor with the RV device, which can either be just for RV pacing or VDD mode, where it senses the mechanical action of the right atrium and tracks it, can be anywhere from 10 to 16 years. The dual chamber leadless pacing system, when you actually have these devices communicating wirelessly with each other, is about 11 years for the RV piece and about 6 years for the right atrial piece. So not really that long. However, what some physicians are now doing is they're actually shutting the communication between the right atrial and the right ventricular devices and leaving them without direct synchrony, which dramatically improves the battery life. 10 years for the atrial device and 19 years for the ventricular device. It's a little bit like DDI pacing, except that there isn't a paced AV delay. And for some people, that gives adequate AV synchrony. In the VDD system, again, that one that has the accelerometry data to sense right atrial contraction, as I alluded to before, it works outstandingly well in some patients and not so well in others. So that's something to keep in mind. Leadless pacemakers can be retrieved or extracted. In the case of the one vendor's device, that's been shown to be possible for at least a couple of years. After that, it endothelializes enough that it's actually quite hard to get out. With the other vendor that is using this sort of helix fixation rather than the tine fixation, they have special extraction techniques that are supposedly good for even longer term extraction. So one study that looked at the differences in complications between leadless and transvenous devices showed that there were far fewer reinterventions for patients with leadless devices, far fewer device complications, and no difference in mortality. Um, and here's another slide basically from that study. However, in another sort of longer term analysis, even though there were fewer reinterventions and fewer complications, they did actually show in both unadjusted and adjusted analyses that there was a higher mortality among patients with leadless pacemakers. So after adjustment for all of the available comorbidities and other characteristics, this difference was less than in the unadjusted analysis. And The common take on this is you can't adjust for the unknown confounding. And most likely it's because patients who get leadless pacemakers, especially in the early experience with these devices, were much likely to be far older and far sicker. And that is the thought as to why there were higher mortality among those patients. So in comparison, when selecting a transvenous system versus a leadless pacemaker, you really have to take into account a variety of patient characteristics, particularly their age. This is not something you would generally do for a younger patient because the battery longevity is not that good. Yes, you can take them out, or if you can't take them out, you could put a second right ventricular leadless pacemaker in over time. But I don't think they're quite ready to be the long-term pacing solution for a 30-year-old. You also have to understand their anticipated pacing burden as well as how important AV synchrony is to their cardiac function. Hostile anatomy, like vascular malformations from surgery or radiation, or long-term venous access, as I showed you in those couple of examples, would tend to favor leadless systems if feasible. People who are diabetic or immunosuppressed or have chronic vascular access have high infection risk of transvenous devices, and so that might favor a leadless system. But in all cases, you really have to have careful shared decision making with the patient and their family when describing the pros and cons of these approaches. Here's one of my former residents or interns at Hopkins published this recently, and I thought it was a nice picture showing some of the characteristics that would favor leadless systems versus traditional transvenous systems for patients. And it kind of um, summarizes the things that we were just talking about. So initially, there weren't many clinical trials for pacing, and I think one of the reasons for that was it was assumed that pacing to prevent asystole was better than the alternative, and therefore it wasn't appropriate to do clinical trials. I mean, it would be like doing a randomized clinical trial for another life-saving device like parachutes, right? Well, what's funny is a couple of years ago, one of my friends, Bobby Gay, and some other friends of mine actually published in the British Medical Journal in 2018 a randomized clinical trial for parachutes versus empty backpacks when jumping out of airplanes. It's sort of a tongue-in-cheek article, but I encourage you to find it because it's actually pretty well done. And basically what they found was that the RCT showed no difference in jumping out of an airplane with a parachute versus an empty backpack. However, the reason for this was lack of enrollment of high-risk individuals. And so essentially what they saw is that anybody who was at 9,000 meters elected not to participate, and people for whom the airplane was sitting on the ground said, sure, I'll try that. And here's a young woman jumping out of a stationary airplane on the ground with a backpack with no parachute and not getting injured. Eventually, there were pacemaker clinical trials, and some of the more important ones actually were early on to investigate what happens when you have chronic right ventricular pacing. So the most trials studied about 1,300 patients with sinus node dysfunction and narrow QRS. They were randomized to dual chamber pacing or single chamber right ventricular pacing, and the endpoints were heart failure hospitalization and development of new atrial fibrillation. This was Mike Sweeney at the Brigham, and what they found was that for dual chamber pacing, if your cumulative RV pacing burden was more than 40%, you didn't do so well with regard to heart failure hospitalization or AF incidence. And for single chamber only pacing, the same difference was found when you got to about 80% ventricular pacing. And this may have something to do with AV delays and so forth. But the idea is that more right ventricular pacing was probably not good for LV systolic function or for the development of AFib. The Made It 2 trial, which was an ICD trial that we'll talk about more in the future, also demonstrated that a higher proportion of RV pacing actually led to a higher incidence of heart failure. And it showed also with regard to ICD tachytherapies. So they found a significant difference in heart failure, the composite with mortality and ICD therapies, and a non-significant trend toward an increase in mortality, believe it or not. So I'm proud to say, and you should be too, that at our very own institution at the Cardiovascular Institute in 2005, the MIDAS study group actually looked at this in about 12,000 patients in the state of New Jersey and compared single chamber pacing patients to dual chamber pacing patients to those who were not paced. And they found that single chamber pacing in particular, but also dual chamber pacing, was associated with a greater risk for heart failure hospitalization and mortality. So based on studies like this, the PACE trial was initiated. It looked at only a couple of hundred patients with bradycardia and a relatively normal left ventricular ejection fraction. They were randomized to RV pacing or newer technology called cardiac resynchronization therapy, which we'll describe in a moment. But suffice it to say, CRT is thought to be more physiologic and maybe won't help to increase the risk of heart failure. And they studied the endpoints of ejection fraction and end-systolic volume, as well as the 6-minute walk and some lifestyle questionnaires. And what they found was that biventricular pacing, or CRT, was associated with much better outcomes. In fact, the ejection fraction didn't decline as it did with chronic right ventricular apical pacing, and the end-systolic volumes remained small in that group. Similarly, or in addition, I should say, they found that patients with a wider QRS tended to derive more benefit from biventricular or CRT pacing. So with this in mind, are there solutions for patients who require a high burden of ventricular pacing? Should we do CRT, or are there other things we can do? And the answer is there are other things that we can do, something called conduction system pacing, and we'll address this later in this presentation after we talk a bit about ICDs. So implantable cardioverter defibrillators, there's a long history here too. Michelle Morawski and Mort Maurer at Sinai in Baltimore developed these devices. Once they were getting ready to implant them, they moved the whole endeavor over to Johns Hopkins Hospital, where Mike Weisfeld, who was actually my chairman when I was there, helped to push this through. Levi Watkins was the surgeon who actually did the first implant. These devices were intra-abdominal, they were large and they were heavy, and they were shock-only devices. Here's some pictures of the first devices. So this is not a small operation. There's a big thoracotomy to implant both a SVC lead and also a ventricular cup, between which they would do the energy delivery. And sort of a cute historical note, here's the pulse generator here on the upper left. These were initially called automatic implantable defibrillators, or AIDS for short. And recall that this is 1980 when they developed this. So after a few years, as the HIV epidemic really grabbed the country and the world, they had to change the name because they didn't want to be, quote, giving people AIDS. And so initially the name was changed to AICD, automatic implantable cardioverter defibrillator, and ultimately just ICD. So modern transvenous ICDs are much like the pacemakers, other than that they can also terminate ventricular tachyarrhythmias, either by a high voltage shock, which results in cardioversion or defibrillation, and more via something called anti-tachycardia pacing, which we'll talk about some more. They can also be pacemakers, multiple chambers, or with CRT, and modern devices last between 6 and 15 years, depending upon various characteristics. And these are designed to prevent sudden cardiac death, excuse me. And they do this by, as I said, detecting ventricular tachyarrhythmias and either shocking the heart to restore a perfusing rhythm, or by anti-tachycardia pacing, which is essentially ventricular overdrive pacing. You can kind of outrun the tachycardia and terminate it. However, ATP can sometimes accelerate VT and make it more likely that someone would receive a shock. And so clinically, these are normally programmed in zones by rate. Here's a relatively common set of programming. It's a little old-fashioned now because we have trials that show you probably shouldn't program these devices to act under 200 beats a minute unless you have a good reason. That's beyond the scope of this talk. That's, in any case, that's called mated RAT. But you can see that for the fastest arrhythmias, over 222 beats per minute, you try ATP a little bit, and then after that, shocks. For somewhat slower VTs, you have more opportunity to try ATP, 3 rounds of burst pacing, followed by shocks. This is a radiograph of a single chamber ICD with an RV lead, just the same as a single chamber pacemaker, other than the fat line here is the RV shocking coil. And it is between this coil and the pulse generator that the high voltage shock is delivered to convert the heart. Here's a lateral. This is a dual chamber ICD. So a little bit more about anti-tachycardia pacing. As we said, this is a technique designed to terminate ventricular, or in the case of atrial ATP, atrial tachyarrhythmias, but mainly it's to help avoid high voltage therapy when possible. You could do burst pacing, which is at a single cycle length, ramp pacing, where you decrease the cycle length, in other words, pace faster. And there's a newer algorithm, something called intrinsic ATP, which I'll just touch on a little bit. So here's some tracings from a device interrogation. Here's the patient in a relatively normal rhythm. Well, they're a little fast, about 120 beats a minute. Here we go. They have a tachycardia with a cycle length of 240 or 250 beats a minute. It is rapidly detected by the device, and 8 pulses of anti-tachycardia pacing take place here, and it successfully terminates the VT, resulting in a safe perfusing rhythm without a shock. This doesn't always work. Here's a similar VT in another patient. Here's anti-tachycardia pacing. Again, 8 pulses. It did not terminate the VT, didn't actually accelerate it in this case. Another round of ATP might have gotten a touch faster after that. And the way it was programmed for this patient, after 2 ATPs, if that wasn't enough in this rate zone, it was programmed to deliver a shock. Here's a high voltage shock, which then terminated the VT. Intrinsic ATP is a new algorithm that has actually been shown to be better at terminating ventricular tachycardia. Without going into all the gory details, essentially what it does is a little bit like when we do EP studies in the EP lab. Based on the return cycle lengths after doing ATP, it uses that information to know if it got into the circuit and what the appropriate um, extra stimulus cycle length should be to try to terminate the tachycardia. And it tends to work pretty well. So what are some of the complications that can happen when people receive ICDs? Basically, all the complications that we discussed for pacemakers. And with all of those complications, again, you may need system extraction or lead revision. So is there a way to avoid some of these complications with alternative ICD designs? Excuse me. So one of the alternatives is to have something called a subcutaneous ICD. So there's a pulse generator that gets put in the left lateral thoracic pocket, and a lead is tunneled in the subcutaneous tissues to the left side parasternally. And basically, this can shock the patient when VT is detected. It, however, cannot perform anti-tachycardia pacing. Interestingly, this device can pace in the post-shock period to prevent asystole following defibrillation. However, because the lead is tunneled in the subcutaneous tissues, you need very high output to do this. It's kind of like doing transcutaneous pacing, so it's very painful. And therefore, you can't use it either for ATP or for bradycardia prevention. However, because there's no intravascular lead, there's no intracardiac lead, there is the possibility of fewer long-term complications. So here's a cartoon of what these look like. This is one I did a couple of years ago. You can see the pulse generator in the left lateral chest, and then this lead tunneled alongside the sternum. Here's a lateral. There was a study a couple of years ago in the New England Journal that showed that there was no difference in the combined endpoint of device-related complications and inappropriate shocks. But if you look at these outcomes separately, you can see that among the transvenous ICDs, they were much more likely to have device-related complications. In other words, the sub-Q ICD achieved what it intended to do, which is to say we're going to have fewer infections, we're going to have fewer vascular problems with this system. However, the trade-off is there were a lot more inappropriate shocks in the sub-Q ICD group. This is because sometimes people would get inappropriate shocks for supraventricular tachycardia or when there was T-wave oversensing leading to double counting of the rate. And also appropriate shocks were more common because since these devices can't provide ATP, the only thing they could do to terminate VT was a shock. So since you can't provide ATP with a sub-Q ICD and you can only rely on shock therapy or high voltage therapy, are there alternative designs that you can use? And the answer is yes. So one of the companies recently came out with what they call an extravascular ICD. This is similar to subcutaneous ICD with a pulse generator that's on the left lateral chest. And then using a subxiphoid kind of mediastinal approach, you tunnel a lead into the anterior mediastinum near the heart. Because the lead is so close to the heart, and it's not just subcutaneous, it can actually perform antitachycardia pacing. In addition, for short periods of time, it can provide pacing to prevent asystole in what it calls pause prevention pacing, and that's selectable for pauses between 5 and 15 seconds. Here's a radiograph of one that my partner did not that long ago. You can see the pulse generator here and this kind of sigmoidal lead that's not quite epicardial, but in the anterior mediastinum near the heart. If you look closely, you may see the lead here. That's in front of the heart. So not to be outdone, that other manufacturer who came up with the sub-Q ICD now said, well, wait a minute. Now that we have leadless pacemakers, maybe we can hook these up and essentially use the sub-Q ICD with all the known benefits in reducing complications and connect it to a leadless pacemaker, which can then provide antitachycardia pacing and potentially also pacing for bradycardia. This is not yet approved. However, the probably pivotal clinical trial was just reported a couple of months ago, and so it's likely that this will become clinically available within the next year or so, would be my guess. So when comparing the various types of ICDs, again, you should think about the patient age. And that's particularly important with ICDs because we treat a lot of people who are very young in their 20s and 30s with a high risk for ventricular arrhythmias, like patients with Brugada syndrome or patients with ARVC. And thinking about their lifetime, if they're in their third or fourth decade of life, the number of lead revisions and generator changes and so forth with potential for vascular complications is much greater than implanting a device in a 70-year-old. And so for a younger person, you may really want to consider a non-transvenous ICD. That said, you have to figure out how much they might require ATP for termination of their arrhythmias, what their pacing requirement can be, because even the newer non-transvenous devices don't provide much pacing, excuse me, much pacing support. And again, all the usual infection risks and hostile anatomy and so forth. I love this slide. I borrowed this from a friend of mine in Boston. This is another way that an ICD can prevent sudden death. This, I guess, if you look at it this way, fortunate patient was actually shot in the chest and the bullet hit his ICD pulse generator. So, indications for ICDs. Again, sparing you all the nitty-gritty from the guidelines. There's a bunch of different reasons. There's secondary prevention devices. These are people who have survived a sudden cardiac arrest, were revived with ACLS, and once you exclude completely reversible causes like an acute MI, these people need devices. Patients with a low ejection fraction, typically 35% or less, and heart failure symptoms get what's called a primary prevention ICD. And then there's a whole host of electrical and structural cardiomyopathies that can have ICD indications. The vast majority of the ICDs that we implant are in these first two groups, and in particular in the low LVEF with heart failure, so the primary prevention ICDs. And most of our recommendations now are based on a number of clinical trials. I'm going to spare you most of them, but there's a couple of clinical trials that are pretty important to talk about. One of them was MADE 2, and this is patients with history of MI with a low ejection fraction. And this is one of the two major ICD trials that was able to show benefit in mortality, for which we now have FDA approval and CMS approval for these devices. And then SCUD-HEFT a few years later combined patients with both ischemic and non-ischemic cardiomyopathy and heart failure with a low EF and found that there was a benefit for ICD implantation with regard to mortality. I always find it interesting that amiodarone really showed no difference in placebo in extending life with ventricular arrhythmias. But in any case, if you break out the ischemic versus non-ischemic cardiomyopathy patients, there was a bit more benefit among the ischemic cardiomyopathy patients with a number needed to treat of only 12.5 as compared to 17. So in the modern era, excuse me, post-viral cough. In the modern era, we now implant over 100,000 ICDs per year in the United States, and most of the trial data are now more than 15 years old. And the question is, in the modern era, when we have very good goal-directed medical therapy, does this still make sense? So in Denmark a few years ago, they actually studied this and looked at patients where they randomized them to to ICD therapy versus medical management only, and they didn't see any difference. And this is the forest plot showing that there wasn't much heterogeneity, with the exception of maybe the youngest people deriving some benefit. And so this was sort of a bomb dropped on the EP community, and we tried to figure out explanations. Well, there was a very low event rate. Maybe that was the problem. Everybody had great background goal-directed medical therapy. They were on lots of good medications. And for people that had indications for CRT, they actually got CRT without ICDs necessarily. So a long-term follow-up study with a median follow-up of almost 10 years redemonstrated the same results, but again, with the exception that younger patients may benefit. And so with this in mind, there is now starting the CONTEMP ICD trial, which is PCORI sponsored, randomized, multicenter, open label clinical trial. We're going to be participating in this trial. And basically what we're doing is we're randomizing patients with non-ischemic cardiomyopathy thought to have a low arrhythmic risk by a variety of metrics to ICD versus medical therapy alone. So getting back to high degrees of ventricular pacing, what options do we have for patients? Well, we talked a little bit about CRT before. CRT systems, again, provide biventricular pacing. The way that we do this is with an RV lead and then a left ventricular lead that's placed transvenously into a coronary sinus branch, coronary venous branch, excuse me, via the coronary sinus, usually on the posterolateral wall of the LV. If the anatomy is unfavorable, we used to put epicardial leads surgically with a mini thoracotomy, but we don't do that anymore because we have conduction system pacing, as you will see. Here's an example of a CRT device. This quadrupolar lead over here is actually in a posterolateral branch, as you can see on the lateral. And with CRT, that's a CRT pacemaker, the idea is that if you have a wide QRS, particularly a left bundle branch block, the left lateral wall of the left ventricle is activated very late. And because of this, the mechanical function and the strain rate of the left ventricle is not good. So the theory behind this is if you can pace the left side of the heart early and synchronize it with the septum, you can restore electrical synchrony and thereby mechanical synchrony and increase the LVEF. Well, it turns out that this works. There's some pressure volume loops in the bottom to show you how this may work. There were a number of trials, but MADIT CRT was probably the best one. A couple of thousand patients with ischemic or non-ischemic cardiomyopathy and a low EF and a wide QRS. They were randomized in 3-to-2 fashion to CRT versus an ICD without CRT. And what they found was the combined endpoint of survival and heart failure was better with CRT. What they didn't see in the original study was a mortality benefit. However, they did show that in the long-term follow-up. I thought it was kind of cute that in the original study, decreased heart failure hospitalization, but no difference in mortality reminded me of the DIDGE trial, which is something many of you know about. But some of the important things to see in the analysis here was that patients with non-ischemic cardiomyopathy seemed to do a little bit better. The wider the QRS, people did better. And also people of female sex, I guess we're not allowed to say gender anymore, did better. And this showed improvement this just shows the improvement in left ventricular performance. And so what about the QRS morphology? Is CRT only beneficial for left bundle patients? Well, there was an analysis in MADIT CRT by QRS morphology, and it showed mainly that people with left bundles did better. In particular, people with non-left bundle QRSs actually did a little bit worse. And if you look at the long-term survival data, in particular, with left bundle branch blocks, people did much better with CRT. But without left bundle branch block, even though their QRS were wide, QRS durations were wide, they didn't seem to benefit. And one of the most controversial and eye-opening things was that there may have even been a significant trend toward harm. So most electrophysiologists, or most honest ones these days, do not implant CRT systems in patients with non-left bundles, particularly with right bundle branch block. This just goes to show again that the wider the QRS, the better. And unlike the original study period, in these patients, mortality benefit was seen in longer term follow-up. So although more benefit was seen with the wider QRSs and with left bundle, are there some patients with narrow QRS that could benefit? So this was studied in echo CRT, and the bottom line was there was no benefit. In fact, the DSMB actually stopped the study. So we don't offer CRT to patients with narrow QRS. This is just a graph to show you on the left that the wider your QRS is, the more opportunity there is for benefit with CRT, provided you have a left bundle. So CRT can improve your ejection fraction, your New York Heart Association heart failure class, reduce mortality. And again, it's better for people, maybe only good for people with left bundles. The wider the QRS, the more benefit, non-ischemic cardiomyopathy, and female sex. And this is just a slide to show you what the current CRT guidelines are. Generally, people with a left bundle, a fairly wide QRS, and a low ejection fraction. But there's limitations. Sometimes people have bad anatomy. They just don't have a branch where you can put a good lead. Depending upon where you put it, you may get phrenic nerve stimulation of the left phrenic nerve, leading to power hiccups, as I like to call them. The lead electrodes can move, and that can sort of ruin your thresholds and your battery life. About 30 or 40% of people don't actually respond, meaning their ejection fraction doesn't get better, even though they have a left bundle. And all these people with a non-left bundle QRS morphology really aren't great candidates for CRT. So what else can you do? As I said, we used to ask surgeons to put epicardial leads, but now we have something called conduction system pacing. So this can be either His bundle pacing or left bundle branch area pacing, or the combination of one of these and CRT. So in His bundle pacing, we actually do almost like a mini EP study to try to locate the His bundle, and we screw a lead into that area to capture the His bundle. This can result in extremely narrow QRS. As you can see here, the patient started with a right bundle, again, somebody we wouldn't do CRT for, and ended up with quite a narrow QRS. And this has been shown to actually improve the combined endpoint of heart failure hospitalization and death. And it can even improve heart failure class and reduce mortality, and is potentially helpful in people with non-left bundle QRS morphology. The problem is it's not so easy to do. The pacing thresholds are almost always higher, and the dislodgement rate is high because of the fibrous tissue that you're screwing into. And in addition, what if somebody develops infranodal block at the level of the His bundle later? Then they may be asystolic. So is there an alternative? And the more modern alternative, which is what the field has moved to, is something called left bundle branch area pacing, where essentially below the His bundle, you locate a spot on the septum where you get a certain pacing morphology, and you screw deep into the septum to capture the left bundle. Here's an example that I did not that long ago. To prove to you how deep the lead is, here's an echo of that patient where you see the lead fairly deep in the septum. And this again can result in substantial narrowing of the QRS and improvement in ejection fraction, New York Heart Association class, and potentially mortality. There are only very small studies so far. This is a study in 2022 where patients seem to do better with left bundle pacing as compared with traditional CRT. Here's another study from 2023 with a few more patients in it. And again, the combined endpoints of heart failure, hospitalization, and mortality appear to be more beneficial for left bundle branch area pacing. However, the data are still to come. So it again has the advantages of His bundle pacing, but may be safer and is certainly easier and with better battery life of these devices. But questions still remain regarding the long-term studies that are now ongoing, and also how difficult it might be to extract a lead that's so deep in the septum. So when comparing these techniques, virtually nobody is really doing His bundle pacing anymore, but left bundle versus CRT, mostly you would think of left bundle pacing for people for whom CRT is not feasible or don't have a left bundle. And again, there are still non-responders, maybe 30% of people. This is probably due to distal conduction abnormalities or intraventricular delays, or maybe infiltrative cardiomyopathies, where the ventricle is so scarred, no matter what you do, you're not going to get a narrow QRS and improve the EF. You can try the combination of left bundle pacing or his bundle pacing and a CS lead, and that has shown some benefit in, again, a relatively small study. So these devices can also, besides the pacing and the arrhythmia termination aspects, can detect arrhythmias and can learn things about heart failure as well through thoracic impedance monitoring, analysis of the heart rates, heart sounds, and so forth. This is one of the vendors showing changes in thoracic impedance and some of those other indices to help you understand when somebody's heart failure is getting worse. So there are now other devices to finish up that are helpful for treatment of heart failure. Cardiac contractility modulation, or CCM, is actually a device that paces in the refractory period of the ventricle, which interestingly is thought to affect calcium handling and actually improve cardiac contractility. This device is shown here. It requires a couple leads in the septum, and it's indicated for patients with a low-ish EF, 25 to 45%, without indication for CRT and on good goal-directed medical therapy. Here's one of those devices showing the two leads in the septum plus a right atrial lead. And it has been shown in selected patients to actually improve New York Heart Association functional class and also VO2 max. Another newish device uses baroreflex activation therapy. And basically, if you activate the sympathetic nervous system, or sorry, activation of the sympathetic nervous system and underactivity of the vagal system are thought to play a major role in heart failure. So if you can stimulate the carotid sinus body, you might be able to reverse this and help heart failure. And so there's a device that you could stick on the carotid sinus body. This is what it looks like. It's tunneled up here into the neck and down to a pulse generator over here. This patient also happens to have a defibrillator. And that has been shown to increase exercise capacity in selected patients as well as to improve other heart failure associated parameters. And finally, wireless pulmonary artery pressure monitoring can be much more helpful than just looking at ICD thoracic impedance and other factors intermittently. The long text block here comes directly from the FDA approval for this. But basically, if you have bad enough heart failure and you've been hospitalized and need invasive monitoring, this is a way to do it wirelessly. So basically, there's a sensor that can go into a pulmonary artery branch. It's very small. That's it compared with a dime. It's implanted kind of like doing a swan. I'm not sure if any of you can see the device here, so to help you, I've blown it up. There it is in a small pulmonary artery branch. And a pivotal study in the Lancet showed that if you use the device data, if you use the PA pressure monitoring, you can actually improve heart failure, both in the treatment group during the randomized phase and in the control group when it was open access afterward. They did even better, actually, once they got access to their PA pressure data. And I know that some of our heart failure attendings are now implanting these. So in the future, we look forward to better tools for left bundle branch area pacing. There's some technical challenges on how you do that, which the EPs know about. And for maybe the combination of that and CRT, we really need big clinical trials of left bundle versus traditional CRT. The left versus left trial is ongoing, but I don't think we're going to get data for at least another 4 years from that trial. The holy grail really is conduction system pacing, like left bundle pacing using a leadless device. There was a group that published doing that in the left ventricle with an ultrasonic stimulation system. You don't like leaving stuff in the LV because of thromboembolic risk. But more recently, one of the vendors announced that they've achieved conduction system pacing with a right-sided leadless device that is not yet clinically available. Wearables for monitoring are going to be big in the future. And then finally, stem cell therapy, I thought was kind of cute to mention. This is from a research paper that I found not that long ago, where in a canine animal model, they actually induced hypervagatonia. And you could see complete heart block here with a very slow ventricular escape. They transfected or implanted mesenchymal stem cells into this animal model and showed that when doing hypervagatonia, it actually gave a decent escape rate just from these stem cells that were able to have their own intrinsic rate. And in a further proof that this was working, these mesenchymal stem cells were implanted in a particular place in the animal heart. When they induced hypervagatonia, you could see that they were beating much faster than you would expect a ventricular escape rhythm. And then after stopping this, they did some ventricular pacing at the site where the stem cells were implanted. And because the pace morphology there was the same as the escape, they sort of proved that that's where the escape rhythm was coming from. Anyway, in summary, there's a number of current strategies for permanent pacing, traditional transvenous devices, leadless pacemakers. You could do CRT, you can do conduction system pacing. The optimal strategy for ventricular pacing varies, and current trials are now ongoing, like left versus left, to compare CRT to left bundle branch area pacing. There's a number of types of ICDs, as we discussed. There's also a number of heart failure focused implantable devices that I threw in at the end. And selection of the appropriate device for a particular patient really has to take into account a variety of their characteristics, age, comorbidities, vascular anatomy, and so forth, and pacing demand or arrhythmic burden, but should always include a very detailed shared decision-making approach with the patient. Thank you for your attention. I hope I didn't go over. I think it's close. My introduction was rather long, so I think I was probably on time. Thank you very much.
Thank you so much, Will, for that fantastic talk. If I could, we'll just have 5 minutes for questions and answers. If I could maybe ask you a question.
Sure, please.
We've all learned about CRT. It decreases all-cause mortality. It improves heart failure symptoms, increases the 6-minute walk test. But however, as you had mentioned, about 40 to 50% of the patients do not show any reverse remodeling, and those are quote unquote non-responders. I know that we look at QRS duration. Should we be looking more at QRS morphology? Should we be looking at even patients with more than 35% EF? What are your thoughts on it?
That's a terrific question. First of all, I think the non-responder rate that's quoted is usually about 30 or 40%, but in clinical practice, sometimes it's a bit of a crapshoot. I do think I glossed over a little bit, maybe. One of the sort of standard indications for CRT over the past few years has been based on the PACE trial, saying that if you have a high burden of pacing, even if your ejection fraction is reasonably normal, you may wish to pursue CRT to avoid pacing-induced cardiomyopathy. I do think the focus on QRS morphology is very important because, as we saw in mated CRT and echo CRT and the long-term results and sub-analyses from mated CRT, it's really the left bundle patients that we tend to be helping. That said, conduction system pacing with either His bundle pacing or left bundle branch area pacing can often lead to dramatic QRS narrowing, not just for left bundle branch block type QRS patients, but for right bundle branch block QRS patients or bifascicular block patients. And so we have seen observational data, and we do it every day in the lab. We often see a dramatic reduction in the QRS duration. How well that is going to ultimately translate to increase in left ventricular performance, whether that's by EF or heart failure class, in small studies it works. But we really have to prove it before we say this is the end of CRT and we'll just do, left bundle leads for most patients. The one exception, as I alluded to, is that people with very distal conduction system disease or infiltrative cardiomyopathies, where no matter how well you pace the conduction system, you're going to end up with electrical and mechanical desynchrony later on in ventricular depolarization. It's kind of hard to treat those patients. And that's always going to be probably at least 20% of patients that we don't yet have a good answer for.
I think this is fantastic. What do you think? I know currently the guidelines do not recommend us to move from RV apical pacing to a CRT. If the EF is preserved, do you think it'll come to that?
It may, especially, I mean, they sort of do if someone is in complete heart block and you have a very good expectation of a high RV pacing burden. The way the guidelines are written now, if I'm not mistaken, is that the EF has to be 40 or less to consider that. But many of us are putting in conduction system pacing leads now. In fact, many of us are now putting in conduction system pacing leads for younger patients with sinus node dysfunction, thinking that at some point as they get older, if and when they develop significant AV block, why not pace them in the most physiologic way we know how to do now?
Which makes complete sense. There are a couple of questions in the
Sure.
chat. Dr. Barrett is asking, he thanks you for the wonderful presentation, was wondering if you could comment on the role of wearable diagnostic devices for arrhythmia detection.
Absolutely. Well, first of all, thank you very much to Dr. Barrett for being one of my mentors for many years. Wearable diagnostic devices, such as smart watches and smart bands that people wear around the chest, have been shown to be pretty good at arrhythmia detection. There was the Apple Watch study a few years ago that, although imperfect, was dramatically better than not looking at the detection of paroxysmal atrial fibrillation. The algorithms there right now are based mostly on pulse cycle length variability, and I suspect that they will get better in the future through the use of more electrogram data. Right now, one of the only ways known to do that is to have a concomitant bracelet on the contralateral wrist, so you can essentially get a lead one EKG. But it'll come to that. And I think it wasn't in the context of this talk. We often now implantable loop recorders for detection of occult AF in patients who've had a bunch of strokes or even sometimes one stroke thought to be cardioembolic. And as good as those devices are, I really do think that they'll be replaced in the coming years with wearables. And I think the other benefit to wearables, separate from detecting paroxysmal fib, which is, of course, the most common sustained abnormal rhythm, is in detecting pauses and AV block or potentially ventricular arrhythmias. So I think we're getting there.
I see Dr. Moreira. He's in Argentina. He thanks you, Will, for the formidable presentation. And Dr. Moreira, do you have a question? Please feel free to unmute yourself.
Can you hear me?
Yes, we
Yes.
Can you
can.
hear?
Yes.
Yes. Hi, Bill. Greetings from the summertime in the southern hemisphere.
Thank
Uh,
you.
Just rub it in,
um,
Dr. Moreira.
I have a question and a comment. I have a friend that I think is still working in Cedars-Sinai in LA. They were working on culturing sinus node cells and implanting those cells in the myocardium, I don't know, in the atriomyocardium. Or it seems to me that it was very interesting to think about biological pacemakers. um, do you know any work that you mentioned something about stem cells?
Yeah, so the
Um,
the work that I showed is a little bit old, but there's a variety of groups working on this. And as much as we electrophysiologists love doing devices for people and conduction system pacing and all of that, I was mentioning that leadless conduction system pacing is kind of the holy grail, but the holy grail above that would be a biologic solution. If we can implant cells with automaticity into the sinus node or into the AV node and correct these problems, that's far better than having a device. I just think we're still probably 20 plus years away from that.
yeah. Thank you. I enjoy your lecture from the beginning to the
Thank
end.
you. Another long-term mentor of mine.
Okay.
Will, I think one last question
Sure.
for you. I know that all the Apple Watches and the devices are synthetic ECGs when you look at the 12 lead ECGs that you
hmm
get. How they don't even have like one single lead. How accurate are they?
Well, in the tracings that I've seen from, since you mentioned the Apple Watch, the Apple Watches, are generally a 1-lead EKG, because what I think you do is you have a sensor on the wrist and then you touch the crown of the watch with your other hand. So they give you a single lead. The what's it called? The Cardia devices from AliveCor, there's a 1-lead version and I believe a 6-lead version now that actually give pretty good tracings. With the 6-lead version, I think the way it works is you hold it with your 2 hands and you stick it on your leg, which gives you, enough of Einthoven's triangle to generate the frontal plane. The tracings are actually pretty good, and I have patients who will come in and bring me the tracings from these to say, is this AFib? Is this heart block? Um, that said, and I could be wrong, most of the AFib detection currently done via the Apple Watches is due to pulse cycle length variability, because they don't have continuous electronic data, or sorry, continuous waveform data. They just have the pulse waveform from a sensor that looks at what the pulse is. But it will get better. All they need to do is either have somebody with a watch or a similar device on both wrists, and that's been tried already, or potentially maybe a necklace and a wrist watch or something like that. We'll get there. The question, actually, if I may, is what to do with all of this data. As it is, and Dr. Barrett, and I don't know if Dr. Maglione's still on, for patients with implantable cardiac devices, and we have a couple of thousand managed in our clinic, it is a huge volume of data for us to manage and go through and act upon. When half of the US population or the world population is wearing these devices, we really are probably going to have to rely on AI algorithms and other techniques to really pre-screen most of this voluminous amount of data before bringing them to an electrophysiologist, because there's just too much data.
Yeah, I used to get all these additions into Epic,
Yep.
all the tracings. Yes, you're absolutely right. Bill, I don't see any more questions in the chat. Thank you so very much for this fantastic presentation.
My pleasure.
And we'll see you all very soon.
Okay, thanks,
Bye.
guys.